Honorable Minister and our dignitaries in the room, yesterday we had the overview and the objectives of this first National Health Financing Dialogue, and key among them is on the issue of finding not just resolutions and recommendations from this dialogue, but very strong ones. This is quoting the Honorable Minister of State, who was our guest of honor yesterday. We also had very informative presentations, some emphasizing what some of us have had and probably have been knowing for some time, but urging for faster and quick action on moving speedily from just words to action. Honorable Minister, distinguished guests, we also heard that the private sector's participation as local investors within the health sector was actually put on the spotlight. But we also heard from a renowned private sector player within the health sector that the phrase private sector is here for profits is something that needs to be debunked. And he urged that they are within the space for sustainability, to sustain their activities, and that is their support in this. Honorable Minister, also, because this is not technical, it's non-technical briefing of what happened yesterday, we were also very generous in awarding of new names to some of the speakers. And not because we were generous, but because pronunciation sometimes can be a challenge for us. And a few of our dignitaries or speakers were baptized new names. And we apologized, but they accepted the apology for that. And because today is the final day and we have a very rich presentation in terms of presence of those who are here, I want to urge that we have very honest, very raw, very real, and solutions-focused dialogue, because that is what will be able to move us forward on the subject matter that we have. And if you're hearing my name for the first time, or hearing me for the first time, or even seeing me for the first time, as always, my name is Eugene Anangwe. And I'm not alone. We have a sign language interpreter on the bottom of the screen. He's called Fidel Iriza Nimbuto. He's planning to become a seed. And so I want us to kick off the program today, and we'll be able to now hear from the technical discussions that we had yesterday. And we'll be taken through this session by none other than Enoch Ramuza, who's the Health Financing Senior Technical Advisor at USAID IREME, and Dr. Ina Kalisa, Health Economist at the World Health Organization, Rwanda. I want to hear energy as we bring them to the stage to share with us the technical outcomes from the technical discussions that we had yesterday.
Good morning, everyone.
Good morning, Dr. Ina.
I think our task today is quite simple, is to summarize in few words our discussions that we had yesterday. I think, Enoch, we are very fortunate,
Yes.
actually, in this country. National dialogue is not a one-off event. We have what we called Umushikirano, and it happens annually, and it's chaired by the President of the Republic of Rwanda. And so it's our culture to actually discuss together the issues that matters for our nation. And today, we're actually discussing health financing and how we can increase domestic resources for health.
Yes.
So, Enoch, can you, in a few words, summarize the first session, which was basically setting the scene for us before the panel discussions?
Yeah, thank you, Dr. Ina. And it's good to see the culture of dialogue being replicated to the health financing sector, as you rightly mentioned in the introduction. So, as you said, the first session for yesterday was about stage setting. So we were trying to look at the overview and be reminded of the objectives of this meeting, and we revisited some of the key health financing agendas in the country. We looked at the fact that the country is experiencing the double burden of disease, with the challenges posed by NCDs that have been overtaking the infectious diseases. So in terms of the main objectives of ALM, we looked at the country's progress. What has Rwanda really done to invest in health or to really work on ALM objectives? So for more money for health, we looked at how the country's domestic resource allocation to health has been growing over time. From 56 in 2018 to 61 in 2021, and that's the share of the budget that is allocated to the health sector. In terms of more health for the money, we looked at what is it that we are doing as a country to be more efficient. So we looked at the fact that the country is participating in pool procurement. We looked at the HB health benefit package processes that are being institutionalized at the country level to really be effective when we're adding services to the benefit package. We also looked at the fact that we have the performance-based financing, which really looks at quality of services when you talk about service delivery. So in terms of equity in health financing and service distribution, which is the third objective of ALM, we looked at how the country has been expanding primary health care. So health centers have grown from 499 in 2016 to 514 in 2023. We looked at the health post growing from 471 to 1250 in the same time range. 90% of Rwandans are covered under some type of insurance, which is financial protection there, and then out-of-pocket spending is less than 5%. In terms of leadership and governance, the country has also been really doing a lot there. So we have the health sector working group that is functional through the joint sector reviews that are happening semi-annually. And also the recent Rwanda Governance Board report showed that the citizen satisfaction with health services currently stands at 85.2%. So going more into the remarks and what were, some of the speakers really came on. So the Honorable Minister of Health, Minister of State for the Ministry of Health talked about, the efforts that the country has done in preventing communicable diseases, but also alluding to the fact that NCDs are posing a double burden of disease, but also without forgetting pandemic preparedness and outbreak response. He tasked us to really look into two questions. How do we mobilize more resources for health? And how do we pool existing resources to use them more efficiently? Other speakers also recommended the country's progress being a stellar example in the region and on the continent, especially on achieving their budget target and other targets that are set by global indicators. So that is a bit briefly what was discussed in the setting the stage, really talking about how Rwanda has done in terms of health financing and vis-a-vis the ALM commitments and objectives. Could you take us through the second session?
Thank you, Enoch. I think Rwanda has done really good in terms of ensuring universal health coverage for its population. But there are a few issues that still needs to be addressed in terms of breaking the financial barriers from the perspective of the users or of the patient. So some of them are related to a limited benefit package, not being able to actually cover some of the conditions that we know are rising, like cancers and other very expensive services. So that was one of the issues. Number two is we are required to pay a co-payment to access services. And the more you have expensive services, the more the co-pay is actually high for the population. Number three was to look at, especially for the CBHI scheme, is that the premium is actually paid, but it's not well graduated by income level, meaning that the majority pay about 3,000. And so those are the issues that require attention if we want to further progress towards universal health coverage by ensuring that our population is actually covered financially or protected financially. So our speakers were tasked to look at what are the innovative solutions to actually remove the remaining barriers. And one of them was to look at how to leverage technology to actually know exactly who should be paying, how much should the person pay, based on the dynamics of the population using social registry. The other solution that was proposed was actually, we already started doing it, new and innovative ways of financing or subsidizing the CBHI scheme in particular, just by using a form of taxation in what people do every day. We all know we use fuel every day. We know people make calls, etc. And so how can we use those mechanisms to actually subsidize the scheme to improve, I think that was the name that was used, improve the value proposition for the scheme, to make the scheme more attractive to those who are not yet covered. In terms of how do we want to go about expanding the benefit package to be able to actually include NCDs, which we are currently facing the double burden of disease, without overburdening the population or the members. So speakers alluded to, we need to have a clear and transparent and evidence-based approach to include or not to include a service in the benefit package. While we are facing these conditions like cancer, we need the health system to be ready. You need to invest in the infrastructure. You need to invest in training people to be able to actually provide the services that we are including in our benefit package. Lastly, it was to review the co-payment policy. It should be reviewed to ensure that people are financially protected. And finally, we know that for all health systems, it's possible that people will face financial hardship. And the reason is most or many health systems actually charge out-of-pocket payment. And so because of that, we need to know whether our financing arrangement actually protects people to face, against financial hardship. And so the only way to do that is to be able to measure and monitor financial protection. And we heard yesterday that it's actually possible to do that using a nationally representative household survey. And in the case of Rwanda, we conduct every 3 to 5 years integrated living condition survey. And it's a great opportunity to actually leverage on that, to be able to produce that. It's also, so in addition to be able to avail the data sets to compute that, we need also to build our capacity to be able to analyze the information that we get, to be able to know what is it exactly is driving these out-of-pocket payments, what is driving financial hardship in the country, and to be able to come up with policy that will address the issue. In addition to the perspective of the patient, we looked at also from the provider perspective. We know that the country is trying to expand the network of primary healthcare facilities, particularly the health post. And one of the challenges that they actually talked about is under the framework of the public-private partnership, where the private sector will actually be interested to contribute to the expansion of the network. And so one of the challenges, or many of the challenges that they face, is access to finance to be able to, to expand it. And so why do they need finance for? They need finance to have the infrastructure. They need finance to equip the health post, to be able to actually to respond to the need of the population. So panelists also talked about, it's true that we need to have grant funding, but grant funding is not sustainable. And we need to actually be able to use grant funding as a catalytic mechanism to leverage additional resources. Number two, I think they also alluded to the fact that we need to be able to have a de-risking mechanism for local bank to actually be interested into providing affordable loans to nurse entrepreneurs. And then finally, I know that we say that the private sector is here for sustainability, but I think they also need to be attracted by the tariff that we actually provide. So it will be important to actually review the tariff to ensure that as they invest in the health sector, they also get some return into it. I think in nutshell, that's what we discussed.
That's a really good summary for that session. The third session was on sustainable health workforce production and retention, and we saw that without health workforce, our systems really wouldn't be able to function optimally. One statistic that kept coming up both in the panel discussions and in the night during the gala dinner by Honorable Minister of Health is that it would take 185 years to produce the minimum targets recommended by WHO. So that's alarming. That means we need to not continue to do business as usual. So we talked about how do we intensify the training capacity. We saw that some of the challenges that exist, the nursing schools and midwifery programs, the capacity of the training capacity is still very low. They were alluding to the fact that in nursing school, the enrollment is at 50% capacity. In midwifery, it's around 20% capacity. So how do we really intensify the investment into these so that we can really quadruple the number of health workforce in the next 4 years, as illustrated in the 4x4 reform. So they talked about investing in infrastructure for training, expanding the College of Medicine and Health Sciences, but also the role of the private sector and development partners. Some of the challenges that we face in terms of really intensifying production has to do with the fact that there is limited funding to avail funding for students. So the development partners were called to leverage some of their funding to avail scholarships for students so that we can train more people in the nursing and midwifery and other programs that we need as a country. But also to think about retention. After you train these people, a lot of the challenges are around turnover of these health workers, incentivizing. How do we incentivize them? There is a heavy workload in those facilities. So the major themes that came up were both the monetary aspect of incentivizing them, but also they really delved into the non-monetary. How do we provide trainings or career path development, especially for those who are posted in rural areas, for instance? That was one thing that was proposed. And then another thing, when it comes to workload, how do we use the data that we have to analyze the workload and allocate some of this workforce accordingly so that we can reduce the heavy workload, which is usually one of the causes for the turnover. So that was in a nutshell what we're discussing. We know that the government is doing a lot in terms of intensifying production, but also calling the private sector and development partners to join this cause and continue to really produce the numbers that we need, but also retain them. What about the fourth and fifth session? Can you quickly take us through?
Yes. So the following session was looking at how to improve quality of care using medical technology. And so we had a panelist actually discuss the fact that the country actually invested a lot in to digitize the services and ensuring interoperability and exchange of data. So we know that new technology can actually improve the patient experience and as well as outcome. So we had a panelist who actually looked at or explained to us the application of artificial intelligence in the health sector. And so examples were looking at clinical decision support, predicting supplies needed, and a number of them. And some of the challenges that were around using the technology for health was that the artificial intelligence is still expensive in our context. But we also need to look at how can we use it as safety as possible and also ensure that we follow the ethical principles. For the following session, it was looking at sustainability of HIV financing. And so we know that Rwanda has done very well in terms of achieving the AIDS targets, even before the set timeline. The panelists actually looked at how have we achieved such those achievements. So more domestic resources were allocated to HIV, reducing therefore the burden of external financing. They also mentioned integration of HIV services into the broader health system. They also mentioned about the use of data, that it was critical to make some of the allocation decision. And this was due to also flexible donor funding like what we get from the Global Fund. And it actually helped to make some decisions, because when you have the money and you are able to actually decide where to allocate it, where it is the most needed. And the number 4 was that by working closely with the CSO and the private sector, they've seen like the importance of working with them, because they were critical in advocacy and capacity to mobilize more resources for the response. The question was, how can we now sustainably finance HIV? And the panelists actually said we cannot talk about the sustainability of HIV as a parallel discussion. It needs to be seen into the broader context of sustainability of the health sector. So we are not only talking about financial sustainability, we are also looking at programmatic sustainability as well as political sustainability. So aspect of programmatic sustainability was to look at basically how do we ensure effective service coverage? How do we make sure that HIV services are actually centered to the patient, so that there's no interruption in the treatment that they have to receive? So we need to address issues of quality as well. And then it was also clear that we need more resources, more domestic resources to be allocated to the health sector. I know we are already doing great in terms of achieving 15% of the budget allocated to health, but we also have gaps, and those gaps will need more resources. And they need to be more flexible. When they are domestic, they are more flexible. When they are domestic, they are more predictable. So the other element that they were looking at was, how can we get more health with the money that we are investing already? And so we need to invest in impactful interventions. We also need to look at innovation in the way we deliver our services. So, for example, they mentioned instead of doing mass testing as they used to be, they are now doing targeted testing. They were also looking at leveraging innovative solutions in the way they deliver training or mentorship. So I think with COVID, we learned a lot how we can actually use e-learning platform to reach out to most of the healthcare workers without having them to come into Kigali or to the central level to get the same training. And then lastly, I think one of the panelists said there's no magic bullet to this conversation. And so in the journey towards sustainability of HIV, we need to continue talking to each other. And in talking to each other, we need to bring data to the table. And then finally, we need to continuously engage. And it's a collaborative effort. It's cross-sectoral. So I think in few words, or in many words, I summarized the last session on HIV financing.
Thank you for that. And to wrap up the day, the last session was about promoting health equity and access through encouraging private sector engagement. And we saw throughout the sessions, the private sector mentioned some of the challenges. We know there is a limited access to financing, but also in terms of the solutions, they were fostering things like de-risking mechanisms that you talked about, especially for very expensive equipment that are usually necessary in the health sector, and the conversations around how do we ensure that the lenders are protected, but also we are really investing or injecting capital into the healthcare sector. But also we looked at how do we interest the private sector to look at the current challenges and turn them into opportunities. And also trying in the framework of equity, how do we expand our operation to other secondary cities, especially that they are also being urbanized and a lot of the population are based there. And lastly, to think about how to advance equity, one of the panelists talked about how do we, as the private sector, invest not only for profit, but also for purpose. So that was a nutshell what was discussed in the private sector. I think the discussions will continue today now that we have very high-level panels and discussions are going to continue. But in a nutshell, that is what we discussed during the day.
Thank you, Enoch, and thank you for your very kind attention.
Thank you so much.
That was more than a nutshell. So we need to appreciate them better. And I know now as I'm scouting for talent in the work that I do as a media person, I know I have two candidates, potential. Great reporting skills as well. Thank you very much, both for giving us the highlights, the technical highlights from the technical discussions that we had. Now, before we go to the next speaker, it's very important to understand that you get to know, I've heard this a lot, you get to know your friends in your times of need. And we have been able to see this evident through the Global Fund. And it has remained a committed partner in working with Rwanda in its quest to deliver equitable and sustainable health to all. Now, the Global Fund's executive director is here within this particular room, and he's ready to listen, but also to share insights on this important subject matter. Let's appreciate him as we also get to acknowledge his presence in the room. Now, the room is full of other key stakeholders that are important in this conversation on delivering health services through investment. And so I want to also appreciate the presence of the African Union Commission. It is also here. The UN family is also very, very well represented in the room. We have UNAIDS Regional Director is here, the UNAIDS Country Director, UNFPA, WHO, UNICEF, and the private sector players are also represented here. I'm also told that representatives from local hospitals outside of Kigali, the satellite cities, are also here listening in keenly, among other representatives. So let's put our hands together to appreciate all those that are here with us today. We're about to hear the next speaker who's coming to share with us his remarks. He's been very instrumental from a Pan-African perspective, even when it comes to championing for sustainable health. He is none other than the African Union High Representative for Financing the Union and African leader in health financing and special envoy to COVID-19. Ladies and gentlemen, let's put our hands together for Dr. Donald Kaberuka. Like we did until he gets here. We have doctors, they'll take care of your palms. Keep it, keep going.
Good morning. Thank you, Anangwe. Normally, when I'm introduced to such events, at least in the last few years, I'm usually introduced as a former this, a former the other, a former this. So former minister, former president of ADB, former Global Fund, former this. I've had great difficulties letting people know I'm still alive. So Anangwe, thank you for that prefix. But it's a pleasure to be here. And I want to thank the government and the organizers for inviting me. I also want to commend the government and the partners and each one of you for putting this important event together. As I'm sure you heard just now, in 2019, African leaders adopted the ALM, whose goals and objectives you have heard, whose roadmap you well know. In short, how to assure better health for our people. Now, they lay down with great clarity the importance of more money for health and more health for money. They set clear objectives: how much share of the budget, how much share of national income, what is the limit on out-of-pocket expenditures, and then they requested our president to champion this exercise. So what we're doing today, like other African countries are doing or will do, is to take stock where we are and look forward, as you have just heard. So our excellent panel, which is coming here shortly, with very experienced and talented people, with national, global responsibilities, will walk us through where we are, including how Rwanda has managed to navigate that space more than I can explain. So in the 15 minutes allocated to me, I want just to delve in some broader contextual issues, and I'll be making just 4 points. So point number one, as soon as the ALM was adopted, we had COVID-19, with its impact on health, impact on the economies. So it was clear then, as it is now, that meeting the ALM financial objectives would be a bigger challenge, to which now we add a lot of fiscal issues, including debt and the global turbulences. But as they say, behind every cloud, there is a silver lining and lessons learned. And I can think of a couple of lessons from COVID, which are relevant to your discussion. First, COVID powerfully demonstrated, if any was needed, the strong link between health and the economy. In fact, for many countries in Africa, COVID was much more an economic crisis than a health crisis. It demonstrated that health investments have very high economic returns, and so is the opposite. And especially so in countries like ours, where demographic dynamics are where they are. The last census done here in Rwanda showed that 78% of our people are below 35. And those who are below 15 are equal to 35%. Just think of those numbers and what it means in terms of the investment we have to make in the young population. Second lesson from COVID, at least from my perspective, was that robust health systems are the best way to prepare for pandemic, any pandemic, those who have known or those to come. But then there's a question. How does Africa, with a limited fiscal room, do so without chronic dependence on external partners? I say chronic dependence on external partners. Now, here's another lesson. When you critically look at how countries, rich or poor, responded to COVID-19, we find something extraordinary. That the outcomes across countries, rich or poor, were very different. Some reasonably poor countries did extremely well in COVID-19. Some very rich countries did very badly on COVID-19. Even those spending up of $4,000 per capita on health. You have read the literature, I don't have to go through that. And so that for me, and for many people, suggests something important for our discussion. That beyond how much money we spend on health, that is necessary, but it is not a sufficient condition. I'll return to this point shortly. Next, and finally, COVID demonstrated that the importance of looking at our own supply chains, that relying entirely on global supply chains for things we need for our people, like medicines, vaccines, and equipment, is extremely risky. So I want to do, in the next 10, 15 minutes, walk you through some of these points and share with you my views, which might help you in our conversation. But as I say, you have got a very capable panel, which will do better than me in this. So point number one, I want to share with you. So why did countries, rich or poor, perform so differently on COVID response? There is a region, for example, in northern Italy, I think around Lombardy, which did rather poorly on COVID outcomes. But then you have got countries with less income, maybe like Vietnam, like Rwanda here, who did much better than countries spending much more on health. So what is the problem? I think, as many friends have said, the answer is something intangible. It is called social capital. It's called trust. It's called the role of communities. Now, social capital is built not simply on how much money you spend on a particular sector. It is how you collect it, how you spend it, on whom you spend. It is built on effective social safety nets and strong community involvement. I'm sure the Minister of Health, who is here, will be sharing with you how Rwanda navigated this issue, but I cannot overemphasize this matter. The simple focus on how much money we collect and spend on health without incorporating this issue of social capital is vitally important. So COVID tested both our health systems, but also our social capital. Minister, I'm sure you'll be coming to this issue because you did very well on this issue around here, and I think it is vitally important. I believe that while Rwanda did reasonably well on COVID and vaccination than many other countries, is probably built on, I would want to say, a very high level of trust in our public financial management. Look, we're not perfect, but I think the public financial management in Rwanda is doing fairly well on many indicators, and the public knows that. They know that when we collect 16% of GDP in revenue, there is something which they can see, which the money does. So that builds trust. There is low tolerance for corruption. That the public knows. Number two, there are issues around community health insurance, community health workers, as you have heard. Then there's issues around simple technologies, and then institutional coherence. These are things, rather than simply availability of vaccines, which actually enable the country to do very well in the COVID response. But again, I leave this to my friend, the Minister of Health, who will be articulating this. But it has a relevance for countries who are not in this room, like Nigeria, for example. You see, Nigeria, which is the first or the second largest economy, depending how you calculate it, has been spending about $10 billion per year on oil subsidies. $10 billion per year on oil subsidies. Angola spends about $4 billion. Now, the problem is blanket subsidies is that they often don't benefit those actually who need them. They benefit the most those who don't need them. All right? And they're a huge drain on the fiscal resources. So the new government in Nigeria has decided to abolish the oil subsidies, which I vastly welcome. But it's important at the same time to ensure that those who need the subsidies, you have the safety nets for them. So here you have an example of how you can actually raise more resources for health, for safety nets, without asking for more taxes. But that is not subject for today. We can discuss it another time. The second point is around the trade-offs and choices which have to be made as we raise funding for health. In many of our countries, the outcomes of health are not simply a function of how much money you spend in the health ministry. There are outcomes of social investments that we make in water and sanitation, in clean energy, clean cooking stoves, in nutrition, and I could go on. I gather you people call them determinants of health. All I'm saying is, it's not simply how much money you spend in the means of health. It is how you spend across the health determinants. So choices have to be made in the health sector and between the health sector and the other sectors, such as water, energy, agriculture, and so on. In addition, across all these sectors, there are multiple actors, donors, philanthropy, IFIs, international financial institutions, and then specialized institutions like the Global Fund, for which I welcome my friend Peter's presence today. Now, why is this important? Look, over the last 8 years, here in Africa, we have made a lot of progress on infant mortality, on major pandemics and disease burden overall. But we have to acknowledge that it's in many countries largely to a global coalition around international financial institutions, philanthropy like Bill and Melinda Gates Foundation, business, institutions such as PEPFAR, the Global Fund, Gavi, which supplemented the national efforts. Now, the relative share of how much the international effort contributes to each country varies from country to another. But the key point is that whatever share it is important to ensure alignment, coordination, and greater ownership. And that is the point I'm making. That demands very strong collaboration between the Ministry of Health, the Ministry of Finance, and other social sector ministries. This alignment, this coordination is not possible unless there is a whole government approach along these lines. And you could also see that during COVID. But it requires more than government. It is government, it is partners, it is business, it is communities, it is members of parliament, civil groups, each in their own role, but coherently working in tandem. So it is not just the role of the Minister of Health alone. And I'm happy to see that in this room we have many people from other departments, including finance, I hope other social sector ministers as well. The important thing I want to leave here, my friends, is that international support is great. We've together achieved a lot. But one day, it will no longer be there. I'm not saying it is tomorrow, but one day it will no longer be there. And we need to plan for that day. And that planning begins yesterday. And especially at a time when the global system is dealing with multiple competing goals, especially the global public goods, climate, fragility, security, as is the case now. So the point I'm making is that the cooperation between Ministers of Health and Finance and others is not necessary just for the purpose of planning for that day or ensuring coherence, but also ensuring that as we discuss climate, fragility, security at the global level, these things are not unnecessarily put in a competition. There's no competition between climate adaptation and health expenditures. They are one and the same thing. You fail in one, you fail in the other. You fail in one, you fail in the other. Recently, I was visiting a country where, to my judgment as a non-expert, I think the biggest health problem they face is child stunting. They have the highest per capita level of child stunting I've ever seen. And so if you have got climate issues, which they cannot adapt to, and food crops are failing, there will be a problem. Now, is that health or is that climate? And so the cooperation between ministers of health, finance, and others is exactly important for this reason as well. Now, I know I've been given 15 minutes, so and now am I already there? Is that right? That is a good one. So my third point is this. I said I had 4 points. Huh? So my third point is this. I think someone referred to it just now. That was an excellent point. It is true that communicable diseases like HIV, AIDS, TB, malaria, despite a lot of achievements, which was described capably here, remain our biggest challenge. That is a fact, across Africa. But here is the dilemma. The last census again here in Rwanda show that life expectancy is now getting close to 70 years. In many African countries, actually, it's close to 65. Now, just reflect about this number. I hope this does not get me in trouble with some people, but let me say it nonetheless. When colonial powers arrived in Africa, I've checked with different people, statistics were not as good at the time. Life expectancy was about 28 years, below 30. That is at the turn of the century. As I say, statistics were bad, so we don't know, but roughly that number. By the time colonial powers left at the beginning of the 60s, life expectancy was not very far from 40. But if I'm wrong, Nsanzimana, please correct me so that the record is clear, 40 years. Now, in many African countries, it's above 60. And like here in Rwanda, we are now close to 70. Now, that is at once an indication of a huge success in living conditions of our people. It's a huge success, which we have to celebrate. But it comes with a price. The price is the one our colleagues referred to, the increase in non-communicable diseases linked to lifestyle, food, and the rest of it. So, because of the improving economic conditions, health conditions, life expectancy has gone up. But that means, as we look for resources for the health sector, for communicable diseases, we have also to look for resources for non-communicable diseases. So, how do we get the right balance between the two? This is so complicated, I leave this to Nsanzimana. My fourth and last point is the one I referred to earlier. Again, a lesson from COVID. How to ensure that we have access to reliable supplies for what we need for our people. For prevention, such as vaccines. For diagnostics, like testing kits. For therapeutics, like drugs. It was quite painful to see that many African countries during COVID struggled to get even masks. Oxygen. Actually, in my ignorance, please forgive me, I didn't know that oxygen had to be manufactured. I thought oxygen is in there. I was then educated by people who know that, no, it's not like that, Mr. Kaberuka, it's so more complicated. But masks, oxygen, we even had to struggle for that, let alone vaccines. Now, I'm not unaware of the complex nature of this problem, the investments needed, both local and foreign. I'm not unaware of the complications around the regulatory systems, safety, and the realities of the markets and uptake. All I'm saying is we have little choice. And on this, there is a conversation to be had across the spectrum of governments, business, philanthropy, IFIs, and international organizations like the Global Fund, Gavi, and others. It's an important conversation, as we have started here in Rwanda in terms of vaccine manufacturing. It can no longer be that we have to depend on the cheapest point of production. I think that is maybe sensible economics, I don't know. But now we're moving to that point where we also need to look at the reliability of that supply chains, especially when we need it. Now, again, that is another issue which I think there's no longer controversy, but it is one where there is a little misunderstanding in some in the international community. Well, should Africa be entering vaccine manufacturing? But the same was said when India began manufacturing vaccines, exactly the same arguments. And so all I'm saying is it's a lessons we learned, which we have to draw from. So let me end where I began. And now we saw now, I'm ending where I began. ALM was well defined by the leaders. We know the direction of travel. Countries like Rwanda, highly committed. There is significant progress. but we're off track in many African countries on spending per capita or spending the share of GDP. Now, COVID and geopolitics has complicated the fiscal space. New priorities or new ways of addressing them mean that if we're not careful, we end up with competition, as I've just mentioned, between resources for climate change, pandemic, security, which is not necessary. These things are integral to one another. Now, as I end this conversation, can I ask you to put up? I'm just putting here to provoke your thoughts during our conversation. This Professor Chiman from Harvard School of Public Health, when I think they put something in your folders, please look up what she said in this article. And the article is called 21st Century Barefoot Doctors. You can dig it up and see. Now, this is a story, just schematically. 50 years ago, during a period quite difficult in China. By the way, for those of you who don't follow these things, at the time, China was poorer than Zimbabwe. You heard me? So China was going through difficult issues, politically, socially, and so on. But it was also facing a huge problem with communicable diseases. Massive problems with communicable diseases. So what did they do? They mobilized 1.5 million peasants. 1.5 million peasants. These peasants received 3 to 6 months intensive training in medical care. Then they were dispatched to their communities to provide basic health care. But they remained farmers, rice farmers. This is why they're called barefoot doctors. It's not because they were barefoot, please don't misunderstand it. It is because they were part-time in the rice paddy farming in water and part-time looking after communities on the way they were trained. In fact, some people call them farmers stroke doctors rather than barefoot doctors. Now, what does the professor say? She says, this low-tech, low-cost, community-based approach was very successful in dealing with communicable diseases. This is well documented. Those of you in this room who are in public health will know this. It was extremely successful. Indeed, he said that this is what influenced the famous 1978 Alma Ata Declaration on Primary Health Care. Why? Number one, it's universalism, universal health access. It reached everyone. Number two, low tech, low cost. And number three, community-based. Now, Professor is not saying we should go back to those times. Indeed, many experts disagree. Some people think this was okay, but. All she's saying, if I read the article correctly, by the way, even China in the 1980s, when they were getting richer, more prosperous, they abandoned to something else. Her arguments are quite simple. Our fiscal room is very tight. Our population is growing. However, as I think the presenters were saying just now, there are technology disruptions at the moment, such as artificial intelligence. That's big data, which offers an opportunity to innovate. We don't have to go back to 50 years ago. But combining these universalist approaches, community-based, with technology, we might be able to ensure better outcomes at lower per capita cost. Look, here in Rwanda, drones have been used to deliver blood products. Drones have been used to deliver blood products. Cell phones have been used, I'm told, to deliver information on some aspects of healthcare. So, as we talk about more money for health, more health for our money, equity, and innovation, let us think through how we can actually do as much as we can in the context of the world today of technology, of global turbulence, of reduced fiscal room, see how we can deliver greater product. I'm afraid that sometimes we may want to focus, but how much money shall we generate? What is the target per capita? Rather than actually, can we do much more with what we have today, as this country has demonstrated? I want you to reflect on that. Now, there's a lot of expertise in this room, more than I can offer, and we will delve in these issues more effectively. So all I want to do is to thank you for inviting me, for your time, for what you do, and wish you well. Rwanda and Africa will forever be thankful for the commitment you bring to these issues, for the health of our people, and as we search for solutions for the future. Thank you for listening to me.
I think that would have even been a standing ovation, in my opinion. Let's appreciate Dr. Donald Kaberuka. I would listen to him. Thank you. When I said go on until tomorrow, I was saying for myself. I would listen to you the whole day. I think when you mentioned the fact that many African countries are off track on many commitments, a lot of times when I do my talk shows, I hear the issue of political will being one of the biggest problems. And the good news is I'm setting up a Nangwe School of Political Will. And I've been headhunting and scouting for professors who will be in that school. And Dr. Kaberuka, I'll request kindly you can join. Thank you very much. I want us to now be able to go into a very important session, very interesting one. And of course, it's going to also set the tone for most of the issues that we've been hearing since we started this dialogue. And it's going to be a fireside chat. And of course, that fireside chat is with the Executive Director of the Global Fund. And it will be moderated by none other than Dr. Brenda Katera, who's a public health specialist. She's also been leading health programs for the last 20 years. And she's also a medical doctor and a personal friend. Ladies and gentlemen, let's bring in on stage the moderator for the fireside chat, Dr. Brenda Katera.
Good morning, everyone. It's such an honor to be able to moderate this session this morning, and very insightful remarks from our previous speakers. Thank you so much, Dr. Donald Kaberuka. So our next session, we'll start off with a fireside chat and then go into a panel discussion with the various dignitaries in the room. And we are going to focus on enhancing the domestic resources for universal healthcare coverage and talk about the journey towards sustainability, innovation, and quality healthcare. So we have seen from this morning and from yesterday the progress that Rwanda has made in healthcare, the great health outcomes across the different domains over the last 2 decades, and the factors that have contributed to that. At the heart of it, of course, is domestic health financing and the broader health financing strategic plan that has provided a roadmap towards championing the strategic pooling of domestic resources to procure healthcare services efficiently, and ensuring that everyone has equitable access to healthcare and shielding our citizens and households from the burden of healthcare costs. We've heard that Rwanda has met the Abuja targets, allocating over 17% of government resources to health. However, we still have a lot of external funding, which continues to outpace the domestic contributions and have led to significant health impact as well. So the path is multifaceted towards UHC, including private health, supporting private health facilities like we've had, fostering engagement with the private sector, exploring innovative approaches to boost domestic contributions, and expanding the scope of health risk pools. So Dr. Kaberuka has talked to us about the COVID, what we've learned from COVID, and really reinforcing the need for resilient health systems, linking between health and economy, looking at health not as an expenditure but as an investment, and strengthening the supply chain systems. So the objectives of this session is really to analyze where are we as Rwanda, how have we been able to get here, and also how can we showcase the multifaceted approaches to enhancing domestic resources. So the first session, I'll invite Dr. Peter Sands to come up. He needs no introduction. He's a friend of Rwanda. He's the executive director of the Global Fund to fight AIDS, TB, and malaria. He has been in that position since 2018. And he has a distinguished career in private sector. So we'll love to hear some of those neat bits from your experience. And he's an expert between that interface between global health and international financing. Please warmly welcome Dr. Peter Sands to the session. So warm welcome, Mr. Peter Sands. And you, with your experience from the Global Fund, and maybe as starting off with a personal story, as a young medical doctor in the 90s, early 2000s, HIV was a big issue that time. Many of my patients couldn't afford the antiretrovirals. We had to pay over, I think, $2,000 a month for just a dose, and go through the screwing experience of sitting in a committee to decide who gets health ARVs, who doesn't get ARVs. And thankfully to Global Fund Investments and other partners, that is not the picture we are seeing. In Rwanda, we have almost achieved epidemic control, meeting the 95 targets. Due to external financing from the Global Fund, but also domestic health financing. So what is your view on the role of domestic health financing initiatives in improving global health outcomes? And what are some of the successful strategies that have been used to continue to catalyze domestic resource mobilization in other countries? And how can we learn from that as Rwanda?
Well, thank you for the question. And I just want to start off building on your reflection about the history of the fight against HIV/AIDS, because sometimes I think when we look at the problems ahead of us, they look daunting. Climate change, economic problems, NCDs, all this sort of stuff. And yet, what happened with the fight against HIV is, together we made something that looked impossible possible. We went from a situation where very few people had access to antiretrovirals. They cost something like $10,000 a year per person. And we're now at a situation where 25 million people in the world now have antiretroviral treatment. As you say, here in Rwanda, you're on the cusp of epidemic control. And the progress continues. Even in August, we secured another cost reduction on the cost of antiretroviral treatment, taking it down from $60 a year to $45. When you think that it was $10,000, that's an extraordinary change. Also, before I come to the broader issue of domestic health financing, I must acknowledge His Honourable Minister and the government of Rwanda for kindly inviting me here, and for the incredible partnership we have with Rwanda, both as a country to which we contribute funds, but also actually as a donor to the Global Fund. It's been an extraordinary, successful partnership. And equally, I have to acknowledge my former boss, Donald Kaberuka, who was chair of the Global Fund until quite recently, and who I have enjoyed many discussions and debates about all the issues that he set out so articulately. Look, the issue about domestic health, resourcing for health, is fundamental. Organizations like the Global Fund aren't going to be around forever, and if we are, we will be directed by our donors towards the most broken places in the world. the places where the need is greatest and where the most people are dying. And in a way, the challenge for a country like Rwanda is that the better you are in delivering for your people, the faster that's going to happen. And that's a sort of unfortunate incentive because it sort of punishes you for doing a good job, but it's the reality of the way the world faces. And you can understand why donors will want to direct the money to the places where we don't have good government that is delivering for its people. And so the imperative of domestic resource mobilization for health is right here and now. And the good thing is that I think that Rwanda has already been a fantastic example of showing what can be done even in a country where per capita income is just under $1,000 per person. I think the President Kagame, has shown extraordinary determination and political will, both here in Rwanda, but also more broadly across the African continent in his ALM role as a leader for health finance. Let me just touch on a few things that I think are really important, and many of these sort of build on what others have already said. One is it's absolutely critical to talk about health as an investment and not as a cost. The reality is you can't build economic and social development on sick people. They're too busy just surviving. And you need people to be healthy to build economies and to build a broader society. And the returns, as Donald said, on investment on health are ridiculously high. I come, like Donald, from the banking sector. When I first started looking at the numbers on return on investment for health investments, I didn't believe them. I thought they were far too high. And yet they are true. They are incredibly high returns. The second thing is that, and we need to do a better job on this in the world of health, is to talk about the value of the jobs that are created in delivering in health. The climate change community has done a fantastic job in talking about green jobs and saying, you know, when we spend money on things in climate change, we're creating these green jobs, and so we're building broader economic development. We haven't done the same. I don't know what color we would use for health, but we need to be talking about the value of creating jobs, because these are great jobs. They're career paths, they're skilled, they're good incomes. And in that context, I think the ambition that the minister has laid out for it by 4x4 of quadrupling the healthcare workforce in Rwanda in an incredibly short time is a massive thing. I'm enormously supportive of it, both because it will deliver better health outcomes and because it will create an enormous number of very good jobs. There's a lot of stuff within domestic resource mobilization for health and domestic health financing, which is highly technical. The design of health insurance schemes, the public financial management, the role of supreme audit institutions. These are all very, very important. And they are particularly important because they build this fundamental thing around social capital and trust. You can't really run a universal health coverage system if people don't believe in it. And they will only believe in it if they think that the money that comes from them, because ultimately this will come through health insurance premiums or tax payments, if the money that comes from them is well spent. So I think it's absolutely imperative to increase domestic resource mobilization for health. I think Rwanda's example is a superb example of how it can be done. Fundamentally, the key driver is the political commitment to make it happen. But then behind that, you need to have a lot of capabilities, institutional strengths, and technical work to actually deliver on it.
Excellent. So we have the political capability, we have the structures, but we are not yet there. We are still seeing significant investments from external from the country. And this is understandable given the limited fiscal space that we have. So given those challenges and several other challenges that countries in low and middle income countries face, what has been the role of Global Fund to support countries to address some of these challenges?
First is, don't expect the challenges to go away. There isn't a country in the world, however rich it is, that doesn't have a divergence between the demand for healthcare and the resourcing for healthcare. Because I think it's a fundamental human thing that actually the more wealthy a society gets, the more people want to invest in being well and healthy. It's a basic human need. So this is going to be a journey, and there's still going to be these debates, even when Rwanda has a per capita income of about $3,000 or when it has a per capita income of $10,000. But we have to acknowledge that where Rwanda and most African countries are at the moment, the gap between the need and the available resources is vast. And that reinforces the importance of the points that Donald and others made around spending the money on the right things and spending it in the right way. The kind of value for money side of the equation is absolutely critical because we simply cannot afford to waste any single dollar. So what's the role of the Global Fund? Well, the role of the Global Fund, in a way, is to help bridge that gap until countries become wealthy enough to provide for their own people. And particularly to do, I think, two critical things. One is to reduce the burden of the big infectious diseases. That doesn't mean we're going to solve the problem of the NCDs, but it means that we can take that off the table as a big, big driver. Because you'll recall this from your own history as a doctor, but it's still the case in many parts of Africa that the health system is overwhelmed by infectious diseases. I was in northern Nigeria just a few weeks ago, and I went to 5 different healthcare facilities, and in each of them, malaria accounted for minimum 50% and maximum 80% of what was going on. It's very difficult to deal with anything else if 80% of your activity is on malaria. So one basic thing the Global Fund can do is help countries get those diseases down to a level where they are controlled and no longer such an extreme threat. And when I look at where Rwanda has got to, you're well on the way on that path. The second thing we can do is work with countries on building the foundations of the broader health system. So investing in the lab networks, the community health workers, the supply chains, all the different elements of the health system. And we can also help with the specific issues around building more sustainable sources of finance. And we can crowd in other sources of finance through debt swaps and blended finance and that kind of thing. So a lot of what we are now doing with the ministry here is also around things like investments in oxygen, in medical equipment, in the teaching hospitals, in the ambulance network, in areas that go significantly beyond what we do for HIV, TB, and malaria. I think the critical thing is when we do all of this is that I'm not sitting in Geneva sort of saying what should be happening and what should be the priorities in Rwanda. That we are responsive to what the government, the broader community through the CCM are determining as the priorities, and that we act as enabler. I just make one other point, which, building on Donald's remarks, which I think is going to become increasingly evident as we see more of the impact of climate change. Climate change is blurring the distinctions between what is a health problem and what is a broader societal problem. And therefore, the whole of government approach to dealing with water issues, nutrition issues, emergency response to flooding, all gets quite linked, all has to be linked up with the way the Ministry of Health works. I was very struck in northern Nigeria looking at, and I was in Chad recently as well. I'm afraid to say I was focusing in those places because in those places malaria is the biggest killer, on what was actually killing the children. And what was killing the children was a combination. It was the fact that they were malnourished, but not malnourished enough to die of malnutrition, just malnourished enough to be weaker. And they were catching malaria, but the malaria would not have killed them if they had been well nourished and treated. But it was the combination of the two. And therefore, a health response to that cannot just be, oh, we'll only do with the malaria. Neither can you only deal with the nutrition.
True. I think and Rwanda has done a great job of looking at integrated health systems, not just focusing on HIV or malaria, but even leveraging HIV resources to strengthen the health systems. And I'm glad the Global Fund is also investing in resilient health systems for the whole of society approach and the total person approach as well. Shifting gears a little bit to the private sector, we've had challenges that the private sector has raised in terms of limited access to finance. They would want de-risking mechanisms and really ask to make healthcare an attractable investment for the private sector. And I know that the Global Fund has done a lot of work with the private sector engagement. Could you just highlight some of the ways the Global Fund has catalyzed private sector engagement for health financing?
Well, to start with, you were very kind in announcing me as a doctor. I'm not a doctor. I actually come from the private sector.
You are now.
Well, no, I have two daughters who are doctors, and they are very caustic about me saying anything about health, because they say I know nothing about it at all. But what I do know about is the world of finance and economics, because like Donald, we both come from that background. And so I came to this role very much with the view that we need to bring together the strengths of the medical and scientific world, of government, of private sector, of civil society and communities, because these are challenges that we can only overcome if we leverage all those strengths. The private sector, and it's one of the things that makes the Global Fund very distinctive. We have more engagement with the private sector than any other global health entity. When we did our 7th replenishment in New York in September 2022, the private sector contributed 1.3 billion of the 15.7 billion that we raised. Now, that's less than 10% of the total, but 1.3 billion is still a pretty serious amount of money. But also the private sector, we work with the private sector in multiple different ways. Obviously, in many countries, private medical facilities, private pharmacies are a critical part of the healthcare delivery system. And it's really important that they're brought into the broader health management information systems, disease surveillance, and provision of care in an integrated way. Second, the private sector is a critical source of innovation and best practices. And indeed, I was delighted yesterday to see one of the pilots that we are helping fund through our Data Science Catalytic Fund, which is all around providing community health workers with what was a really impressive mobile app that allows them to both do real-time data uploading, so everything they do goes into the system without them having to spend hours writing everything down, and also provides real-time sort of guidance of the procedure that they're working through. Another area that I think is critical, and particularly critical for Africa in the post-COVID era, is local manufacturing. Africa got a very raw deal during COVID-19. A lot of the focus has been on the inequities in vaccine provision, but frankly, if you think about things like oxygen provision or diagnostics, it was worse. Just horrific degree of inaccessibility to these life-saving tools. The approach the Global Fund has taken to helping catalyze the development of local manufacturing is fundamentally to use our size as a procurer. Because one of the big issues about local manufacturing is going to be where is the demand going to come from, and can manufacturers count on it being there 3 years, 5 years, 10 years from now? Because if you're making investments, that's what you need to know. So we have focused on a number of areas where we are major buyers, and we know we're going to be major buyers for a significant period. So in August, we launched a formal call for proposals for HIV diagnostic tests manufactured in Africa. And we did it in conjunction with PEPFAR. So that basically means the two, by far, the biggest buyers in the world doing it together. There was a conference in Maputo earlier this week, which is part of initiating a similar process for antiretroviral treatment. And we're pursuing a similar thing for bed nets. And we've deliberately picked categories of medical product which there is going to be sustainable demand for, and we can deliver it because we are, for instance, bed nets, we are 50% of the world market. Now, there's a lot of issues to make this happen. There are regulatory barriers, there are financing issues, but we are committed to working with partners, and I was with Ajay Banga, the new head of the World Bank, earlier this week, and we are actively engaged with him around ensuring IFC support for local manufacturers. So I am confident that we will make tangible progress on this. As I said, I think it is critically important to be really clear where the demand is coming from, because none of us want a situation where people have invested in factories and then they can't find anybody to sell to. One last point I'd make about the private sector, which I think is sometimes underestimated, is the importance of workplace health, of employee health. And I think this is particularly important with tuberculosis. We've seen some very successful programs run by companies like Anglo American in South Africa, where they've been testing all their employees. And for those of you who are private sector companies, the business case for doing this, you don't need to be thinking, you should be thinking in terms of social purpose, but frankly, the business case stacks up on its own. Before Anglo American did this, they were having 800 people, 800 members of staff catching TB, and TB treatment takes 6 to 12 months. So they were losing somewhere between 400 and 800 FTE in terms of capacity every year, quite apart from the human cost, just the sheer business cost. 4 years later, by running integrated programs through the workplace with our participation, the most recent numbers I saw, they had 8 people.
Wow.
And you just do the math of reducing the lost employment time between 400 to 800 FTE to losing 4 to 8 FTE. And that's a pretty good return on investment. And it also is a fantastic way to demonstrate sort of true commitment to the staff you employ. So I think the private sector has to be involved in multiple different ways in achieving the broader health objectives that a country like Rwanda has. And certainly, I think we can bring a lot of experience of different models of participation, whether it's on data science and leveraging technology, whether it's the Anglo-American example, Coca-Cola being involved in last mile distribution, because they're pretty good at getting bottles of Coca-Cola to pretty well anywhere. You know, we have a whole range of different experiences of working with the private sector.
Well, those are very eye-opening examples. And Rwanda is very committed to private sector engagement. Local manufacturing is a key priority for Dr. Saba and the rest of the government, and will be harnessing some of those opportunities to increase the intersectionality and the collaboration, the partnership that is going to spur us forward to continue to bring more health for the money and more money for the health that we need. Thank you so much. This concludes our fireside chat. And will take us to the next panel discussion. Please give a round of applause to Dr. Peter Sands. Thank you so much.
Thank you.
Now, I realize that you've been seated for quite a bit of time. So I'll ask that before we get into the panel discussion, just stand up for maybe a 2-minute stretch, say hi to your neighbor. Please don't get out of the room, because bringing you back will be difficult. Great. Let's please take our seats again for the next leg of the panel discussion. Okay, please come back into the room. We look forward to the high-level panel discussion, and we are going to hear from exciting speakers, dignitaries that are bringing a wealth of experience from government, from development partners and donors, and as well as the regional bodies from the East Africa community. Some Waiting for you to have your seat. Thank you so much again. And really building onto the discussions that we've had since morning with Dr. Donald Kaberuka, with Peter Sands from the Global Fund, we'll step into more granular discussions. And I'll ask the panelists to come up as I introduce you briefly. First and foremost is our Honorable Minister of Health, Dr. Sabin Sanzimana. Please give him a round of applause as he comes up. He needs no introduction, and Dr. Sabah, you already have some questions that Dr. Kaberuka put out for you, so your work is well cut. Welcome. Next is the Minister of State in charge of public investment and resource mobilization at the Ministry of Finance and Economic Planning, Honorable Janine Munyeshuri. Please welcome her. You're welcome, Honorable Minister of State. We'll also invite the Deputy Director of Global Programs at the Susan Thompson Buffett Foundation, Blen Sahiru. Please welcome her. We'll also invite, we're privileged to have the Director of Social Sectors at the East African Community, Dr. Irene Charles Isaka. Last but not least, I'll welcome Mrs. Anna Bodipo Buyamba, who is the Health Office Director at USAID Rwanda. And please note your questions. We'll go through a quick chat with the panelists. Each of them will be given a chance to say something. But most importantly, we want to engage with you, the audience. So please note down your questions, and we'll come back to you at the end of the panel discussion. I'm already taking public speaking tips from Mr. Anangwe. Thanks so much. Apparently, I need to sit here so that they can look at me.
Okay.
Right. I'll start with you, Honorable Minister of Health, Dr. Sabah. We have seen the strides that the government has taken and the political leadership, the commitment towards a healthy and productive citizen. And there have been several investments that have been made in the health sector from the government. And also, the domestic investment is complemented by external development support from various partners. However, we see the cost of healthcare increasing. We want to increase the benefit package. We want to achieve universal healthcare coverage for all. And like we had mentioned earlier, we still have a limited fiscal space as a country, but we have been able to achieve so much with the limited resources that we have. And building onto Dr. Kaberuka's question, how have we managed to do this? How have we optimized the limited available resources that we have in Rwanda? And given the ambitious reforms that we have as a government, how are we planning to ensure that we achieve those?
Thank you very much, Dr. Brenda. So I think this is a very interesting session. Since yesterday, we've had great panels and speakers. Dr. Peter and Dr. Kaberuka have outlined almost everything we had to cover. Probably we'll be more specific on some details. But I want to highlight that this is one of the dialogue discussions we've had for the last almost 20 years, trying to address the issue of sustainable financing for health, at least for those who have been in this sector for such long. I can remember all the times we sit in different hotels and meetings, trying to see how best can we ensure that health financing is strengthened, sustainable, and we have more, we need or we spend less to gain more in terms of outcomes. But I think the discussion continues while we implement and we see good outcomes happening. So, and I'm sure it's not the last time we are discussing this. Even next year's, we'll keep reflecting on how best we can invest in health. At least we are all agreeing that this is not just spending. It's necessary, actually. There's no other choice than investing in our own health. And there's a common saying, a proverb that says, health is actually the greatest asset that any human being can have. Being in health sector, being in financial sector, being in any other sectors, when you talk about your own health, your body that has to function normally to be able to be productive, it closely linked to the economy and life of people and well-being of people. So there's no other way to explain it that way. That's someone yesterday was asking, how are you convincing the finance minister to invest in health sector? And I struggled to answer that, but there's no difference between me as Minister of Health and Janine as Minister of State and Minister of Finance, as far as we are working for the same people, same community, and ourselves, our own health. So what we do sitting together should be addressing the needs that we see in our communities. And that should be the baseline we all should start from. So there are many elements that we need to look at. First, what's the best way to raise domestic financing or to spend external, even mobilize external financing? It doesn't come just because you're there. You have to mobilize for that. So I think, to me, it should be investing quickly what you have, being domestic or external, to the fact that you addressed the current pressing issue so that it doesn't stay, and you address other issues because they keep coming. And the faster and the more efficient way you do that, the better, because you'll have made people healthier and productive. Then you make more money. They become productive. And it has been addressed already by the previous speakers. It's all about the trust, because people will tend to join and support even the external partners when they see results happening. And they will spend or come to work with you when they see accountability in how you use the little available finances to produce more, to get more results. And there's always a question we ask ourselves, what comes first? Is it the money or the plan or the idea? And from the little experience we have in this sector in Rwanda, when you have the best idea, the clear plan, sometimes what we used to call ambitious plans. I think ambition is all about how you commit yourselves to change things. So when there is a great plan, a clear idea, there's some magic that happens that money will sometimes come. It goes with the explanations, how you communicate that, how you get people to join that ambition, that plan. And sometimes I think also the easy plans or easy goals are not attracting partnership and commitments. And what Peter was talking about, the 4x4, when we brought this idea first, we got feedbacks, oh, this is a crazy idea, this is something hard to achieve. We said, we are not aiming for something that is easy or what we can do faster. It's actually what we need to solve as a problem that motivates us to think of 4 times Then we work on the details, how we get there. And after, we're seeing really support and partnership coming, because addressing the issue of people, shortage of staff, will not only solve the problems of people who are not treated properly, but also these are trainers of other healthcare workers that we'll see in our sector. Two more points before I pause on this question, is the importance of data systems. The more you spend and the better you see where you should be spending is always the best way to be efficient, to make an impact. And data systems have been a kind of secondary investment in most programs, but now it's becoming more clear and clearer that it's a necessity, because it tells you where you start with. If you have malaria, you have TB, you have NCDs, you have pandemics, and you have only an envelope that can cover 2 diseases, what do you choose first, and where do you invest first? So you should be able to have data systems that help to prioritize where we spend first, and excessively, sometimes obsessively, so that you address the first problems before you tackle the other one. Because when you try to spend everywhere with as little resources you have, you end up by not solving any of your problems. And of course, digital and data goes together. We're seeing that with artificial intelligence and digital tools, you can actually achieve more spending less. And the best example is in clinical service delivery, when you think of imaging or cervical cancer detection in diagnostics. With technology, a few well-trained providers can screen and read many images than a few people that you may train for very long time, that you don't have time to train those. So I think we need to embrace those tools very quickly, because that's the best way we can cover the gaps that remains, and probably are not going to achieve with traditional ways of spending. Even if you receive the large amount of money, you're not going to catch up with 50 years lost in the legacy of our health systems. But now this technology are kind of equalizers, where if we embrace it quickly, if we don't, we are going to remain behind in this journey. So I'll pause there. Thank you.
Thank you so much. That's a good segue into Minister Jeannine's question. Dr. Sabah has ambitious plans, 4x4, and there are others that are going to come up. And these plans we've done the costing. They have a huge investment needed to achieve the ambitious plans. And we know that you're receiving these ambitious plans from all the other sectors as well. So given the strong collaboration that we have between the different ministries, Ministry of Finance and Ministry of Health and the other ministries, how does Minecofin prioritize and plan to gradually and sustainably increase domestic resource allocations for health, given that health is an investment and we need the people to be healthy to pay taxes?
Thank you, Brenda. Your question is vast and broad. But before answering to it very specifically, I wanted people in the room, and maybe not everyone, to understand the structure of Minecofin and the current new structure that I joined a couple of months ago, to precisely answer to that particular question of coordination between ministries and the false dichotomy or the false competition between priorities. Indeed, health is a priority, education is a priority, security is a priority, and we don't want to look at them as competing priorities. My docket is new. I'm in charge of public investment and resource mobilization. Formerly, there was not such a specific docket for resource mobilization, and companies in which the government invests, whether it's in full or partially, were into a ministry which was the Ministry of Investment, Mininvest. So currently, I have, if I may say, 3 business lines that I want to describe for you to understand, before talking about resource mobilization, domestic or external, that we want to get to a point where we understand exactly how we invest in anything. So I have my first business line are the companies that we invest in, whether we are, as I said, a full owner of the company or a partial owner of companies. The reason why government would invest in a company historically has been that we wanted to actually de-risk for private sector. And sometimes we also want to be in a sector because it's too strategic to be left to private sector exclusively. So in that capacity, we definitely want to be investing in cutting-edge companies that we think are maybe it's too early for private sector to be in, and we should, as government of Rwanda, be in, including in health businesses. Then you have the second business line, which was under planning before, and it is informed by planning because most of the money comes from our budget. It is what we still call the National Development Projects and Programs, under which there is a strong element of health programs and projects. So 80% of our budget is there. You have huge projects and programs, and this is the real public investment because it's really public money invested in it. And mirroring it, we used to have just a department that was called External Finance, that was putting together the money we get from bilateral and multilateral partners, and it was just a department. So now that we have, I'm trying to get a picture of what do we invest in companies that, let's say, are in health, what do we invest in these big national projects that are in health, but not only health, but I will explain it later. Then, in terms of resource mobilization, it has been said by yourself and by all the speakers before, we are in a context where concessional loans or money from our good traditional partners is shrinking for all sorts of reasons. We thought we would keep external finance as a department, but we need to create an innovative finance department where we would pull in also money from CSOs, philanthropies, and so on. Or why not even create our own investment vehicles of a new sort? That's also informed by probably my background in finance. And last but not least, we created, not by source of funding, a department for green economy and climate finance because it's cross-cutting. It doesn't need to be necessary from a particular source of funding. Once you understand that money we got from external partners will become scarce, and to respond and to echo what Dr. Kaberuka said earlier, we want not only to know how we collect money, so basically our tax base, but we want to understand how to spend it and who to spend it on. In a few months or weeks, by means of a lot of technology and consolidating data together, we will be able to say at Minecofin precisely, this is the money we spend on health. Whether we spend it as an investor or whether we spend it as government in terms of budget money. We definitely want to be spending less on budget and more from other sources. And I want to speak to a second point. So now that I've tried to give you a picture of our Minecofin organization chart, at least on my side, I want to walk you also a couple of ideas we do have and we need to keep deepening and exploring around broadening the tax base and collecting more revenues, and especially revenues for health. We are in a context where our development is still funded, as you all know, by external finance and aid money, even if we don't call it aid specifically. And one of our objectives for the coming couple of years will be to increase our revenue of 1% increase, whether it's by collecting more taxes or so tax reforms, or by administrative measures where we know that, okay, we still have pockets of uncollected taxes that we need to collect. Precisely even in the tax reforms, some of these specific tax reforms will be tied to a direct investment into health sector. let's say taxes on cigarettes, taxes on alcohol, and so on and so forth. It's still under study, but definitely we will do as we implement those tax reforms, directly allocate the new revenues generated to health as a sector. Second, I think it's Peter Sant who touched on it. We inherited of and still have a system of blanket subsidies. If you go to any hospital in Rwanda, and even if you have your mutuelle de santé, however much you earn, you pay the same money for the same service. And reviewing the design of our health insurance scheme has been a priority that CEO Regis and RCSB has been keenly working on. And I think they'll be rolling in a couple of months the new schemes, making sure that we pay for the service, but with a relationship with how much money also we make. This will free a lot of revenue. We first increase revenues in these healthcare facilities, but also will free subsidy space from government spending. Another point that I wanted to touch on, and it has been said a lot, how health is cross-cutting. When we spend as government on health, whether it is spending or investing, because we do both, I want you to remember that health is broad and vast. Because also of our economy, we've been investing a lot, and we still are doing so in health infrastructure. We continuously want to invest in, let's say, recently expanding King Faisal Hospital, the Kanombe Military Hospital, and then the new facility of education that opened. It's both infrastructure and education, ICAD, say, for example. And then you have healthcare delivery in and of itself. Still there, a lot of effort is put. Then last but not least, which is informed by my previous job, health education. In health education, there are opportunities to make good use of the money we get from partners and grants, and this is probably coming in a few months as well. We are going to be launching an endowment fund through which we say government is putting this amount of money. The Susan Buffett Foundation has been giving to the health sector, seconding position, a huge amount of money, and we will go to our partners and other philanthropies and saying, would you match this amount? This pooling of resources will allow us as government to not only attract in more philanthropies and cheaper money, which is not this time debt, but also in terms of efficiency of how we spend and reporting back to donors, we will sit with a broader picture. My very last point before I let all other speakers speak is one that has been touched upon every single speaker since the beginning, data. It's new at Minecofin. We are hiring data scientists. I'm a trained statistician, but we used to look at the past, and we do still use surveys, but we want to extract key indicators to be able to make data-informed decisions. And I'm very much looking forward to it in the near future. And I'll pause there. Thank you.
Thank you so much, Minister Janine. Exciting, exciting developments and reforms coming up. I'm sure that we will benefit greatly as a health sector and our people in Rwanda. Shifting gears a little bit to our partners in external financing, moving to Glenn from the Susan Thompson Buffett Foundation. We know that funders are stepping up and stepping in to support our reform processes. And one of the things that you keep asking us is, how are we going to ensure that this is sustainable beyond the catalytic funding that you're providing? So how are you supporting, shifting your priorities to support institutional strengthening and processes beyond the catalytic funding that you're giving to the government?
Thank you so much. Thank you so much, Brenda. Can you hear me? It's maybe still working. Okay. Thank you so much. Before I begin my response to that excellent question, I should acknowledge that in all your agendas that you see, my principal, our vice president, was supposed to be here on the stage this morning with you, but could not do so due to personal emergency. And as you know, Professor Sanai, big shoes to fill. I will not even attempt it, but I will do my best to represent her this morning. And so coming back to the question, a very fundamental question about how do we make sure that this goes beyond catalytic funding and is sustainable and can build institutions for partners. And I'm going to lean on a lot of the previous speakers this morning, including keynote addresses earlier by Dr. Kaberuka and Peter Sands as well. It's going to be about fundamental shift on how things are done and what is funded. So it's both the process and the what. The first one for us, and this is a key value for us as a funder, as a philanthropic institution, is building dignified partnerships which are rooted in co-creation. And this is critical because any effort that is not led and owned by governments is very difficult to make it sustainable. And in this case, and has been said earlier as well, I'm very happy to add to that chorus of saying Minister Sabah and his entire team at the ministry are excellent examples of what this looks like. A government commitment, clear strategy on what needs to be done, what needs to be prioritized in the country, and then pairing that with co-designing and basically asking what is important to you now and over the coming few years and in the longer run, and what does it take to do that? And really putting our resources where our words are and building and co-creating along with government to ensure that first we're building institutions and we're also allowing governments the flexibility to create, to come up with ideas that they understand to be priorities for their own people. And we consider this not so much as a favor that we do for our partners, but it's a privilege to be able to be in that same room co-creating with these partners. So that's fundamental shift from us showing up as donors saying, here is what we are doing for you. Instead, it is a question of how can we be most helpful to you? What is your priority? And how do we think together with you? And that is a big shift that is still taking it's unfortunately rare, and in the broader donor space, that's not how conversations are happening. We do lament that, and it needs to shift. But for us, as at the Buffett Foundation, one of the key things we do is building those types of partnerships. And to make this effective, like I mentioned earlier, there needs to be leadership, a strong leadership and clarity of strategy, and then we also we come up with creative solutions to support our partners by, for example, for every dollar that we give, or we match a matching system of saying we will put in a certain amount and the government will match that dollar, for example, say with $1, $2, or $3 for each one that is put in a program or an investment. And this allows, earlier as Janine was speaking, that flexibility and ability to say, here's what we have, here's what we're building. And that also, to some extent, for other donors who would want to see something already happening, it provides that example of, listen, here is a program that's already underway. 4x4 has started. Here is the resource that we have. Can you step in this way? And we also hope the way that partnership is built can also be an example for others to follow. So I will just go back to the fundamental point of it is how we do it, ensuring that there is multi-year funding, there is flexibility, and there is conversations that happen that center the priority of each country that we work in. And this is not only in Rwanda, we do this in all of the countries that we work in. But political will, leadership, and clarity of vision is critical, and that's why Rwanda is, above and beyond forward from many of our other partners, and wanted to acknowledge that. So, thank you.
Thank you so much. And the same question to you, Anna, from USA. The US government is one of the major funders of the health sector in Rwanda, and you've been supporting or partnering with the government on various health programs, cross-cutting health systems development, strengthening projects. So how do U.S. government investments support country efforts to ensure that there is that sustainability in the healthcare delivery and provision for all the citizens towards achieving UHC?
Thank you, Dr. Brenda, and thank you for having us here today to really talk about this collaboration that we all are working towards. It's really an honor for me, both representing the U.S. government, but also the health development partners here in the room. This is a collaborative effort, as we all said. This is not a one-time or one or two partners, but a whole collective that is really working towards this broader investment in the health sector. And so today, my challenge is to be able to give you the explanations of what's happening with the U.S. government, but also across our other partnerships and collaboration across the health sector. The one thing I really wanted to reiterate that the Honorable Minister talked about is a trusted partnership. And I believe that the U.S. government has and will continue to show our representation in that we're committed to really shifting how we're doing our work. And so I'm glad to hear also the refrain of the way in which we do our work is just as important as what we do to get the achievements. So within USAID particularly, we are really trying to make the shift of funding decisions being made locally. That decisions are being made by the people and the organizations and the institutions that know what is best to have the impactful change in the health sector. And we're doing this through an initiative called localization. And the goal of localization is really to advance the locally led development of both health systems, the humanitarian assistance that we also provide, to which local actors set the agenda. They develop the solutions, and they mobilize the capacity and the leadership and the resources that make it necessary for that to happen. And we as USA try to be a catalyst to that type of effort. One example I like to share with the audience is the close work that we've done with the Ministry of Health as well with RMS to strengthen the local supply chain. As we were talking about the needs for having investments in vaccine production, medical production here, we believe that our work with RMS has been really fundamental to helping that capacity be up to par for those next adventures that are in front of us. The fact that RMS is procuring health commodities for diseases like HIV/AIDS, for malaria, and for other essential medicines, we're really proud that we've been able to be involved in that partnership. It's one thing to note that this partnership, we have a direct contract with RMS for $75 million, which is an investment, as we talked about before, so that RMS can be the flagship of supply chain logistics in the country and to the region over time. So we're really proud that we were able to partnership in that. Speaking more specifically to health financing, we've done a lot of collaboration with USAID and other actors in the health sector. For example, with CHAI and WHO, alongside with the Ministry of Health and RSSB, we have supported the design of capitation models that will be implemented in Rwanda in 2024. And these efforts are really about how to contain the costs in the public and the primary healthcare system at all levels to improve financial liquidity, and also allowing these facilities to purchase the commodities they need and overall improving the quality of services. And we look forward to having those type of relationships continue. Another example that we are proud as the U.S. government in supporting is in the design and implementation of the financial management systems. We're talking about the systems being able to track, and the use of technology in doing so, significantly to enhance the billing and claims in the system. One example I like to give is the Kwivuza system was recently rolled out nationally. And this system, as a result, has helped health centers to reduce the duration of claims payment from 90 days to 5 days. That's a huge cost-saving effort, and I think we need to continue to have and look for initiatives that will help to stimulate that type of proactive engagement. Again, the sustainability piece is really key. These are all technologies have been co-developed, and again, this reiteration of how that the Ministry of Health has been in the lead, and that the local teams within the Ministry of Health and other actors are ensuring that there's ownership, that there's commitment, and that there's long-term sustainability. We've talked about the PEPFAR work with the Global Fund. Here in Rwanda, as folks know, CDC, the U.S. Department of Defense, and USAID, we continue to support our role in PEPFAR in giving both in response for clinical services, prevention, the supply chain area, as well as system strengthening support, particularly in laboratory and data support, which will be necessary, and we know is catalytic not just for the HIV work that we're doing, but for the whole health sector. And again, as chair of the Health Development Partners, I think it's very important to, again, outline what our development partners across the sector have been able to do. Yesterday, we talked a lot about the work of UNFPA through their Strategic Investment Facility is currently piloting an innovative financing instrument that includes catalytic startups for grants for nurse entrepreneurs. Again, reinforcing the investment in the population of the service providers is very critical. UNICEF has participated in 1,000 health posts with joint programming that includes innovative financing for health posts through nurse entrepreneurs as well. We know Partners in Health, a very valued partner here, has been capitalizing and working with the government to establish land and equipment cost sharing, as well as capital projects for building hospitals, health centers, and health post construction. Again, I think that's a demonstration of where there's capital availability now that can be utilized that will give the room for the Ministry of Health to invest in other sectors and then build upon that. The Global Fund, with Peter Sand here, also has been supporting the Ministry of Health, as we talked about, to introduce a sustainability transition and co-financing policy. I think that's been also very key for the provision of co-financing of disease programs for domestic resources. And with WHO, the support to the Ministry of Health to reduce the number of people facing financial hardships due to the financing needs for health and really strengthening the community-based health insurance. And it's really great that we're having this conversation again too about as the CBHI has been evolving, we're learning and growing and being adaptive to our changing environments. And of course, with the World Bank since 2020, we know that there's been support to government policies for reform, specifically for domestic revenues, with the CBHI scheme, and supporting the government of Rwanda to really identify additional resources that will be necessary to move forward the CBHI theme.
Great
Scheme.
examples.
Yes.
I think
No, so I just want to say, but this is just again to show that there's a lot of efforts that's happening in this room and outside this room, but really want to demonstrate the commitment that does exist within the development partners to work alongside with Rwanda. Thank you.
Thank you so much. I'm getting to your questions in a bit, but let's hear from Dr. Irene from the East Africa community, and just to give us an update, where are we at with the ALM declarations, and where are the other countries, what can we learn from them, and what can they learn from Rwanda on this journey towards domestic financing?
Thank you so much, Dr. Brenda. As ALM, we are now implementing number 7 today. The social sectors, my directorate is responsible for health, education, science and technology, labor, migration, community development, and that's when we talk about gender, youth, people with disabilities, women, social protection, and also culture and sports. So all the social sectors are in one. And when we talk about health, there are some interventions that we have done. And as we have been listening from yesterday, that we want to build on success stories and how the Republic of Rwanda can tap into this. And when we talk about health, I mentioned yesterday is Article 118 of the treaty that established the East African Community. And according to this, partner states have agreed to cooperate in a number of areas in health. So I will give you like 6 points, and I'll start with one, which is to increase cross-border services. We have centers of excellences, and in Rwanda we have 2. We have 6, but Rwanda has 2. And Rwanda has biomedical engineering, e-health, and health rehabilitation sciences, University of Rwanda. This is all about researchers, training, and innovation. And also, Rwanda is also responsible for vaccine, immunization, and health. Supply chain management is also under University of Rwanda. And we also have nutritional sciences in the Republic of Burundi. We had cardiovascular services, United Republic of Tanzania. You have urology and nephrology, Kenyatta University, Republic of Kenya, and oncology and cancer, Mulango Hospital, Republic of Uganda. Why am I saying this? I'm saying this in order to see how best the East African can take advantage of this. So instead of, let's say, a Republic of Burundi to start establishing, biomedical engineering, they can just team up with the Republic of Rwanda into that. That is one of the things that we think is more innovative and is supporting. As at the EAC level, we coordinate. We tap the expertise in the region. And then the second one, which is also important, is we have operationalization of the mobile lab. We have a mobile lab which assisted us quite a lot during the COVID. And this is deployed in partner states and mostly at the border post. And it assisted us during the COVID-19, but later on assisted us during Ebola outbreak in the Republic of Uganda, and also Marburg when we had it in the United Republic of Tanzania. So we could see also this assist the partner states to reduce, the cost in terms of health provision. And then we also mutual recognition of health professionals. So we have harmonized standards and guidelines so that somebody who is a biomedical engineer certified in the Republic of Rwanda can also work in any partner state in the region. So this is also assist us to utilize available resources. And then we have strengthened state national medicine regulatory authorities. And this is basically, I think, is an area which also we can entice the private sector, because we are talking about local manufacturing. We talked about value chain management. We've talked about, issues of vaccine. So we have assessed about 200 medicine dossiers, and we also assessed and approved more than 100 medicines in the region. That it means, if let's say it's a Panadol that is being manufactured here in Republic of Rwanda and it's is certified, can be sold in any other partner states. So these are the areas that I think we have been working. Another area is digitalization. And I think we have heard from the key speakers, even the previous speaker, the honorable ministers here, they talk about data. And this is something that I think the Republic of Rwanda can learn from other partner states. We have digitalization of reproductive, maternal, newborn and child and adolescent health. And we have a digital scorecard. And I'm glad to say one of the countries, some of the countries have adopted this. And this is a very important scorecard because with limited resources, you can know the concentration points. You can target 20%, which is giving 80% results. You can know which parts of the country they are suffering from which areas, depending on your interventions. So we have launched one in Zanzibar in March this year. And you can trace even where you see the weaknesses, where you can add efforts, and where you can avoid duplication. And another one, which I'm going to spend more time on it, is on regarding the health insurance. And we are talking about universal health coverage. And yesterday I mentioned about 3 tiers. The first tier, which is the universal, which is we normally use to have it financed by taxes and part of it development partners. And the second tier is the one which is contributory, mandatory contributory, which is financed by contributions from employees and employers. And also the third tier, which is purely private, and that is where you find the private sector investments in that area. So for universal health coverage, there are a number of interventions that have been done, and we saw this, I mentioned yesterday, during the COVID era, where the cross-border was a problem, especially moving from one partner state with your medical insurance, which is not recognized in other partner states. So somebody is sick, cannot access medicines, just because the package that he's having from this country is not recognized in other country. So we have not done portability per se, but we have done coordination, so that partner states can start coordinating and accept. And here we have also we have private sector who are providing medical insurance. And we are saying this because when you look at the cross-border, mostly are the private, the small business persons and different people, but you find the one from the public employees, they don't cross much, but you find the traders, these are the ones who cross much. So we are working on the coordination and waiting for approval from the council, but we have already done the consultation with all partner states. And also, now, the innovation in terms of universal health coverage. Yes, there are some countries, they provide matching funds. And when you talk, and yesterday we heard about public-private community partnership. And this is very important, and we heard in the morning about building trust. If they know what they're contributing, it's coming back to them, that can entice them. But how do they contribute? We have different countries, some parts of our partner states. Members, especially in the community, they contribute in cash and in kind. So you may have, you have farmers, tea growers at the collection centers. The tea is weighed and it is priced. So let's say for this package is 10 kilograms of tea, then you give 10 kilograms of tea and then you have, that package. There are some who have, trays of eggs in terms of, then that one is costed at the end of the month, then that one is converted into your contribution. And also another one is, apart from there are some districts even they contribute chicken. They contribute chicken. So those are the innovative kind of structures that can also include people who are not able to contribute cash. And also, the packages differ from one level to another, and these are the areas also, if you find you have a community or you have your people in the nation who are able to contribute, it's important to entice them to contribute so that the government has less burden to take care of these ones who are unable to contribute. So the government incentives as well could be to the private sector in terms of equipment. Yesterday they were saying about interest rates are high. So when you go to borrow from the banking sector, they charge you as they charge to anybody else. So these are the areas where the government can have, they can undertake or they can negotiate with banks to give slightly lower rate. And also, they can also move from purely project financing, but going to the lease financing, so that when you are borrowing this machine, that machine becomes your collateral, instead of having another collateral. So these are, I can talk so much about this, but what I want to say, yes, we are progressing well in the ALM number 9, which is this one, but more work needs to be done, but there are so many innovative ideas. Data is very, very important, and information to people, keep them engaged, build trust, Because even government working with the private sector needs a lot of trust. I worked initially as a public-private partnership advisor, and I could see, areas that we need to build trust so that we can work together. Thank you.
Community involvement, community engagement, building trust, and working off that social capital, I think, has sustained us till date, and we need to continue investing in that. Thank you so much, my panelists. We'll move to a few. We are way behind time, so we'll just take a few questions from the audience. Dr. Anita, your hand was so quick to go up, and then we'll have Dr. Brian after.
Thank you so much, Brenda, and thank you so much to the panel. Thank you. I have a question that comes back to what Dr. Donald spoke about earlier, financing for the health determinants, how we continue to look at health beyond the health sector. And this question goes to both Minister and Minister of State, but also to Dr. Irene at the ESC, and to all of us actually in the room in a way, because it could be at regional level, at national level, at continental level, and also at global level. We are looking at how do we best finance or mobilize resources for health and not looking only at the health sector. So I'm thinking of the example of how within the government of Rwanda, we have the social cluster, we have the economic cluster and all that. And so we meet there and we speak priorities. But when we go to the Ministry of Finance, or when we go to the bank and the different international partners, we go individually. So how can we use forums like the clusters to come up with the priorities that are joined, so that first, before we talk about individualized sector priorities, we have some joint priorities that we all kind of speak the same language to, so that when it comes to the Ministry of Finance or other financiers, we look at it first, the bigger priorities shared by many, and then we go down to the others. So I'm just throwing out this thought to see how do we look at it at national level, regional, continental, and global. The second, please permit me just one quick one, is on supply chains. We are talking of the importance of local manufacturing. We all know how much that goes with the market. Peter, the ED of Global Fund, earlier spoke of how the Global Fund is working with PEPFAR and other DPs on putting together their resources so they're a bigger market. Now, when it comes to governments, when it comes to blocks like ESC, how are we looking at how will we bring these markets together, most especially when we are looking at domestic finances, when the different governments have different ways of procuring and different ways of working. If we don't come as a strong market, then the local manufacturing, will also continue to look at this as a high-risk area. Thank you very much.
Thank you so much. I'll request that the subsequent questions are brief, concise, and please introduce yourself and where you're from.
Yes, my name is Dr. Brian Chirombo. I'm the WHO representative to Rwanda. I'll try and make it quick. I had a couple of questions, but I'll make them briefer. So again, thank you very much to the presenters and panelists for excellent interventions. Special acknowledgement to Dr. Kaberuka. As Honorable Minister said, you said it all. And I think that's what we were mentioning earlier on, that we actually need the other sectors talking about health, advocating for health, and that's really very impressive. I think first comment to Dr. Kaberuka. With HIV, with TB, with malaria, and now with emergencies, what the AU has done has been to push the issues to be handled at the head of state level. Now, we have been talking about, yesterday we were talking about UHC, universal health coverage. We know that primary health care is the best way of achieving that. We are still struggling. I think the health sector is talking. Yes, we have few people like Dr. Kaberuka, but generally, this has remained in the health sector. Multisectoral is not there. The AU, yes, it has addressed different components, but it has not taken a comprehensive approach. What can be done to make sure that this is elevated to head of state level so that we really start looking at PHC and financing of PHC? because that's still a major issue, that we don't have enough resources there. The second quick one is to Mr. Sands. I've worked in HIV. Most of my professional life has been HIV. So when I started working, HIV had exploded. And my wards were packed full of HIV patients, TB patients. And I've worked for the last 22 years in HIV. So I know HIV really quite well. I agree with you that we do need to continue with a lot of investment in infectious diseases. But we know that at this stage, that 74% of, yes, I'll be quick, 74% of deaths currently, yes, I will, 74% of deaths currently are as a result of NCDs. So when is the Global Fund going to begin to look at a shift so that we begin to address some of these, and we talked about the determinants of health, NCDs, etc., because it's important to deal with communicable diseases, but we need to start also addressing other components. Thank you.
Thank you. I wanted to highlight that Mr. Sand had walked out, so we'll address a question maybe over a lunch break. Thank you so much. Can we take 2 more questions? Yes, please.
Good morning, and thank you so much for this panel. My name is Anne Githuku Shongwe. I'm the UNAIDS Regional Director for East and Southern Africa. I actually wanted to talk about this issue of intersectional, multi-sectoral, and to just say that we have had such great success with the HIV response by having built systems that fell under, in many countries, HIV responses remain under the leadership of the Prime Minister or the head of state to ensure that there's a multi-sectoral response. But what we are seeing is as the treatment focus of HIV grows, because obviously the numbers have grown significantly, there has been a consolidation into health specifically and leaving out some of the multi-sectoral, the other sectors that have been crucial. So I think that as we explore how we think about social determinants, and really this is directed to you as the Minister of State, Madame Jeanine, who is responsible for public finance, and to just, how do we think about the financing of social determinants that are beyond and outside of the health sector? We talk about it, but we don't do it. Education, water and sanitation, they are funded already in and of themselves. But how are we thinking about it, or how are we doing it to link it to the health financing, so that as we think about sustainability, we are thinking about sustainability to prevent HIV. I think that's one. The second one is that yesterday, my colleague actually raised the fact that, you know, you can use HIV as an example, that if you look at the performance of a country like Rwanda, and we're seeing this in every one of our other countries, we see a general excellent response in the country when we look at the high indicators. But when you break it down, it differs from region to region within countries. So the inequalities in terms of investments are different within countries. And so you will, you know, how do we redistribute that so that we don't risk leaving parts of a country behind? And, you know, so looking at, and those are linked to social determinants. They're linked to inequalities in regions where the resources are less. So just how to think about the multisectorality and how to think about the disparities across regions. Thanks.
Thank you so much. And lastly, Dr. Kwabena.
Thank you very much, Dr. Brenda. Mine is more of a contribution. And first of all, I have to say, like Mr. Peter Sands, I'm not a medical doctor. I'm a development practitioner. I'm the UNFPA representative. The 4x4, in my view, is a game changer. And I really want to commend my brother, Dr. Sabin, on that. What we need to do is that different entities are contributing to the 4x4. And based on what we heard from USAID, we need to rethink and maybe retake a stock and look at all the 4 dimensions and do a critical mapping as to who is doing what and what is potentially lacking. I'm very confident you're on the right track because the agreements you signed with the Ministry of Education, this has to go beyond, because if you look at the 4x4, it has different elements that relates to different ministries. So it will be good to start getting those agreements with the different ministries so that we have an integrated approach in terms of moving forward. Thank you very much.
Thank you so much for your questions. Let's first respond to those. I think a key question that came out was financing for health, social determinants of health as a cluster. And Minister Janine, I think that will go to you.
I'll take both questions from Anita and Anne together.
Yes.
Because as much as they are different, they are quite the same. Anita is speaking of the structure we have here of sitting in terms of prioritizing needs in a social cluster for health and economics cluster for other sectors. And Anne spoke about another very creative idea, which actually we do use, how to use health financing to address the other determinants of health, including social determinants of health. So for Anita, literally, the question you are asking is the question I think every Minister of Finance asks himself or herself, and all of us should be asking how to not forget a cluster, or how to, when we get to implement the budget, or before we implement the budget, and how do we prioritize priorities. I'm going to share my thinking on this, and it's my thinking, and it's not the Minister of Health thinking. At this particular stage of our development, because of the growth we have seen the past few years, one thing we should also first agree upon is that the growth in the health sector has been bigger than the growth of our GDP. So speak of prioritizing priorities, I think health has been actually given a big chunk of the budget through various ways of financing. That's a fact. Now, at the development stage we are at, and the pressure on our shrinking fiscal space, I would first advocate for one idea that will not make me many friends in my ministry and across, of consolidating. Consolidating these big projects as well as the companies we have invested in as government to make sure that we free fiscal space. Because, this is our envelope, and maybe we have redundancies, we have stalled projects, we have to redirect the way we have decided things before. It takes quite an effort even to look at this big picture. That's one. Second, we are getting at the end of a cycle, the end of NST1, which is the National Transformation cycle we have been, and we are going to enter a new one for 7 years, and all of them sit under this Vision 50 we have set up for ourselves. My thinking, it's again my thinking, is that the indicators we had under NST1 were somehow too vague, too specific, or not calibrated to what we have today. I am advocating to a kind of super cluster where we sit, all sectors, and decide what are the big questions we're going to be answering to as a country. From outlining the big questions, there will be forced collaborations that we have never done before. We might have new ways of working. I don't believe in setting up, working with the same indicators and saying, we haven't reached for a number of indicators, we have 50%, 70%, and let's carry forward those areas in NST2. I feel like the model is kind of exhausted, or not creative enough, or not adapted to where we are. So after this fiscal consolidation of sorts, that will be difficult to make because every ministry wants theirs to be first. We will have to sit together and decide what are the big questions we need to be addressing and we won't address them as a ministry, as a sector. It just won't be possible. And this, I think, is the most exciting part of the next part of our economic journey. And last but not least, to fund our ambitious projects, I don't think we need to stay in the debt category we are in. We are still in the moderate. We were lower. We went to moderate because of the shocks and the vulnerability. We have 2 shocks. We might even consider, what if we were to become a middle-income country, what is the reasonable risk to take to get there, and then decide to go there. But we can only go there because we have this discipline in spending, because we have this big understanding of the top priorities and the broader big questions, which I think are not captured by the format of NST, whether 1 or 2 that we are going to be crafting. So basically, I'm answering to your question with more questions, but with a bit of an approach that seems to be mine today, and I'm going to be discussing with all my colleagues. To Anne, I'm going to tell you that in Rwanda, actually, we have been using health financing to fund and support the other social determinants of health. I think it's you from USAID who mentioned PRH. Typically, PRH, as they were funding antiretrovirals, they decided to really empower communities. So this is health financing that actually address the other social determinants of health, and PRH, both as a global organization and PRH Rwanda in particular, has championed that. You should sit with Dr. Joel, who is in the room, or maybe you know him, to just share the journey of PRH. I still feel that the stride forwards we have made in using or divesting some of the money we have crowded through health financing into other sectors has been not well documented. I feel that we need to encourage our students in our universities or more papers, really, to document the creative journey through which Rwanda has gone to make the strides forwards in terms of actually health output. It's under-documented, and it's been a lot through divesting some of the financing in health and other sectors to the social determinants of health. And the same answer I would give, the second part of my answer to Anita will also apply to this. We have to become richer. And we won't become richer by the same thinking. If as an economy we grow more, we'll be addressing those other determinants. And these could and should be, I think, coming from a stronger financial sector, bringing more equity in, maybe more private banks, creating more jobs. We have a development bank. I think a measure that is not for development banks as a whole, but should be included in ours, it's a measure of impact. How many of those other projects for young people do we fund? How do we capture them? How do we measure them? I think there's room for other metrics to address those issues and monitor them, rather monitor them. But yes, for the multi-sectoral approach, it has been actually one of our DNAs, the multi-sectoral approach, and as I said, maybe not enough documented. I think it's papers for academia, papers for just small papers, short papers, to inform conversations we have, and I'm a big advocate of it. If I had to go back to school, I would do some kind of work of this type. Thank you.
Thank you so much. You clearly need to document our lessons and best practices and share those. Dr. Sabah.
Sure. Thank you. Minister Janina, I think he has explained very well the questions of Dr. Anita. I think working through clusters, like social cluster, brings together key ministries. And even to me, I would look beyond just the social cluster itself. For example, the greatest example is the COVID times when we're handling this pandemic. Sitting together, having Minister of Education because schools were closed. Next, you have Minister of Infrastructure because roads were blocked. There were no trucks coming, bring fuel and so on. So you have Interior, you have local governments. It's really beyond. And I think what the government of Rwanda has been trying to do is working as one government instead of having each sector or each ministry, even each cluster in isolations. When it comes to funding, for sure there will be discussions, each ministry, each sector looking at where we can share or invest first. What are the priorities among many priorities? I'm sure it's not an easy job for Minister of Finance, but at least we've been looking at what can we do that impacts bigger to our communities. So looking beyond our own sectors, not being too selfish to what comes to our ministries, also helps a lot, and we are so much mobilized around that. On the supply chain versus the market, I think this is a whole discussion happening on local manufacturing in Africa, on the continent and beyond, because we've seen post-COVID active phase, almost all countries trying to go into manufacturing vaccines and treatments. Then it was like a marathon when you started at thousands, and as you move on, a few countries assess and stay. Then now we have a few that still think we can do, but not for just specific countries, but for the continent. I think there's still need for that kind of coordination at country level, but also at regional and continental levels. And I'm sure my colleagues of African Union and other entities that are looking at how we work together around that. Because the more we are coordinated, the better we're going to manufacture, but also have the market. The price, unit price will go down, and then we solve this issue of inequity in access to basic products. So I want to point out on the 4x4 and why this, I agree with you, coordination and working together towards this is the best thing we can do in health system strengthening. And we look at it from epidemiological kind of basic thinking about who, the people we are trying to, if you put yourselves into normal citizen, who do you want to see at a hospital or the health facility? You want to see the person who is well-trained, well-equipped, and then you're talking about what is that person using, the equipment and the medicine. And then you talk about where this person is working. You want to be received in the best infrastructure, clean, safe, and also how this person is going to receive you. This is about systems. And we have to always adapt and review the systems we're working in. In our reforms, we have also primary healthcare system review, the community health workers. And at the end, maybe most important or not, if those other 4 pillars are well strengthened, how much are you going to spend to all those steps? So to me, you can build a hospital in a year or 6 months even, if you're too fast, but you can't train neurosurgeons in 6 months or 1 year. That's the importance of training people very quickly, because it will take time. And the more we delay, the more you're going to suffer, even spend more moving forward. So it becomes an urgency, not just a strategy. So it's something we must do, like Donald said. It has to have happened like yesterday. Even yesterday was too late. So that's why I agree with you. We need to come together, have clear targets, put ourselves on a certain speed, and we put ourselves on a certain level of accountability and check. We committed to train 100 gynecologists and midwives. How many have we achieved this time? How many have we enrolled quickly? So this is the best way we can actually measure ourselves towards target. Otherwise, to remain plans and ideas and not implementable.
Thank you so much. I was going to grab Dr. Kaberuka before he goes out to respond to Brian's question, but we can get to him later. Thank you. Dr. Irene, maybe a brief comment on from an EAC perspective. Is there a hope for regional pooled procurement to strengthen the supply chain?
Thank you very much. Yeah, I fully agree with Dr. Anita. Yeah, we are working on that. It's one of the projects. But we also, you mentioned something which is very critical, the issue of having, now we have what we call donor fatigue, because you find this donor is financing, is supporting this intervention, which is also have the same impact as another intervention, which is also supported in another department or another country. So for us at the EAC, we want to coordinate that. That's why we are here, and I'm here with my team. Please, my team, you can wave your hands. So that, yes, we need to coordinate to avoid this donor fatigue, and so that we have, targeted and focused interventions which, give us results. And I know now, even the donors, they say there's a game changer now. What they want, they do not want to see full of activities. They want to see the impact. What is the impact that is going to bring it about? I'm having a colleague there, Dr. Katende. He's having a very good malaria strategy for the region, but has not been able to secure funding. So you'll find donors are also funding, each partner state, small bit, but if we coordinate our efforts, that will be the way to go. And I fully agree about the value chain, the pool procurement. This is also part of the area that we are working together. And I said yesterday, now with 7 partner states, we are looking at the population of 300 million people, of which I think already market is already there. How can we bargain and get these medical commodities at affordable, so that they can reach the grassroots? And we know that the medical inflation is higher than the normal inflation that we have. So these are the things that we need to work together in order to address. And the EAC, these are the critical areas. I just mentioned a few, but there's a lot of work going on there, but I know we'll have different fora to continue engaging. Thank you.
Thank you so much. We'll have last parting shots from Anna and Glenn, and then we can wrap up the session. And over to you, Anna.
Thank you very much. No, I think this conversation is, again, going to be continuous throughout these next several months. But I wanted just to re-emphasize, I think, also the discussion points on the multisectorality of health is very critical, that we should be looking at it from a developmental perspective, development of this country. The country is, Rwanda is moving towards middle income status, and therefore, what are the interventions that we can do across different sectors to move in that direction? The U.S. government is very much in alignment with that, and I think all of our other development partners as well, and are open to having that frank and very strategic conversation going forward. So thank you.
Thank you.
Thank you so much. I'm really excited and very happy to be a part of this conversation this morning, and I wanted to pick up on something Mr. Sabah mentioned earlier, which reaffirms what everyone has been saying about Rwanda and Ministry of Health so far, but it was important because it links to everything we have been saying this morning. He mentioned that when someone asked him how he persuades Ministry of Finance to support health priorities, he mentioned, "What do you mean persuade? We're the same team." And that is a big asset. That's a big asset, and that is also what links to the shift in donor behavior and approach to working that will be critical. Is it allows for this kind of behavior this kind of partnership to flourish, right? When we are allowing our partners to shape the priorities and to frame what is important to the country, what looks sustainable to them, then it allows for the flexibility to nurture this kind of collaboration, and for them to input sustainable strategies that may not yield immediate results, but allows for strengthening institutions. And that requires a shift in the way we look at what partnership look like, what support to governments and our local partners look like. And this is also, again, connected to what we said, lessons we learned earlier. Dr. Kaberuka was talking about how COVID has shown us that, largely Africa was left to fend for itself, and we saw that happen in real time. But we also saw it was clarifying too. In our team, we have a way of thinking, yes, that was a devastating time, but it was also very much clarifying on what we needed to do, and the platforms we did not have, the space we did not have to create, and where resources were going globally. And that's what drives our approach to working with our partners of prioritizing their focus, and how centering their voices is also very important. And linked to that is the reality that funding will always be limited, right? Even locally, raising that and combining and collaborating, breaking these silos, even with that, it will be limited. So facing that reality and asking about what should we be pouring these resources into will be important. And that's why it's our focus as we work with government of Rwanda is talking about workforce strengthening and 4x4 and others, and particularly looking at, we're so excited to see the commitment of the Ministry of Health to strengthening community health workers. And as was mentioned earlier, and I'm just really, again, really grateful to be in this conversation because everything is sort of coming together and linking together. The examples we heard about the barefoot doctors and how it transforms for communities with limited resources, that when we pour into solutions that we already have at hand, it can have a multiplying effect. And so it's in different layers, all of these boxes are being checked. And that's also, in a way, a really interesting challenge for other donors to look at as well. What has been the yield of forcing or focusing on certain priorities instead of allowing our partners to shape it? And again, I just wanted to reiterate that and express our gratitude and appreciation for our partners here, and hoping that we will have more opportunities for similar engagement.
Yes, Minister Janine. And then Dr. Sabai will have the final remarks.
Just a minute, really. The topic today was health financing and sustainability in health financing and domestic resource mobilization. But I would not have said anything meaningful if I didn't thank all the partners walking the walk with us, in particular the wealth that we did not mention in this today, the wealth of relationships. It's really through that, and maybe on that, that everything is built. We have created a way of working with partners in such a way that they become embedded in public service. We have a foundation here. You would say that they primarily fund health, but they do more than that. We have USAID here, and Anna, you were telling us how also you are shifting your way of thinking. It's amazing to be part of a country or a government where the old dichotomies about who does what are becoming blurred, because we have cultivated, and we hope to keep cultivating this most important wealth, I feel, the wealth of relationship. So thank you all for your participation, your engagement, your skin in the game in our development. Thank you.
Thank you.
So, thank you. In case I don't have any other chance also to thank you, I would like to appreciate everyone who joined this dialogue. The Minister of Health co-organized it with different partners, the East African community, we have partners here in Rwanda, and the others who are following us remotely. And this is going to continue. And again, this is linked to the championship of His Excellency the President of the Republic of Rwanda for the African Union as a continent, for the African Leadership Meeting, has been highlighted before by different panelists. We want to push this agenda forward. Financing for health should not be seen as an option. It's actually a necessity. We have to continue. And it has to go beyond commitments and ideas and suggestions or dialogue. It has to be implemented, and we need to see results. And the results will be translated in what Dr. Kaberuka has presented this morning, in life expectancy, in people living longer and healthier, in systems that are improved, in hospitals and health facilities that are strong and ready for any health threat and pressure like we had the last 3 years. So my appreciation to all the panelists and our moderator and the speakers, and also everyone who joined this since yesterday. It was really a great time. But let's not leave it here in this room. Let's take it back in our plans, in our action plans, and also our meetings, and then to conclude, 4x4 is our baby. Let's all support it so that we train the people we want to be receiving us in our hospitals, from the community up to the highest level of care. So thank you so much, and have a great Friday and weekend.
Thank you. What more can I say after an excellent discussion? So please, again, a round of applause and appreciation for our excellent panelists. And I'll hand over to Eugene for the closing remarks. Oh, no one can close after the minister, but for his final words, and then please have your seats. Thank you. Thank you so much.
It's been a forum of fasts, and we want to appreciate the panel and, of course, the amazing moderator, Dr. Brenda Katera. Let's appreciate her one more time. I've been scouting for talent, and I've been hearing in this country we have very few female moderators. I doubt. I think it's just that they don't come out there, we don't see them more. And I think I've seen Dr. Brenda, and we'll be seeing her more. Maybe in the next forum she'll be standing here. I'm ready. I think I'm ready to retire. I think we have had everything that we needed to hear. For me, my work here is to just formally, just let all of us understand that the forum has come to an official end. And of course, by the powers that are vested in me through the organizers of this dialogue, I want to confer in absentia. I know Dr. Brenda did mention this, and she was told I'm not a doctor. I want us to be able to confer a doctor title in National Dialogue on Health Financing on Peter Sands, the Executive Director of Global Fund. But that title expires the moment this event ends. I had to add that. So in conclusion, I think we've had so many things, and for me, as a person sitting from outside who helps drive conversations as a media personality, I think there's so many things that the citizens are waiting for. They're waiting to see actions. They're waiting to see concrete results from gatherings like this, so that we move them from not just talk to action. I think we said that. And COVID-19 demonstrated the importance of looking at the health sector. We had that. But are we ready for the next pandemic? Did we go back to sit and wait for another hard reality for us to wake up? We need to start acting from that particular sense. So I've heard also we need to sit together as sectors. What is missing? Is it the chairs? Is it the room like this? What is missing? Is it a moderator to facilitate the conversations? I commit myself to offer myself and my platforms to drive such conversations. So I'm hoping that when I pick my call to call you to come for these conversations on my talk show, you'll come. And so with that, I'm not left by any other thing to say other than to say that you have been amazing, and I've really enjoyed being with you. I've learned new terminologies in the medical field. Now I'll not be a stranger in those kind of words. And so live from Kigali Serena at the National Dialogue on Health Financing aimed at increasing domestic resources for the sector, I'm Eugene Anangwe, signing off.